Come in. Good morning, everybody. Good afternoon and good evening. I'm Elizabeth Ashbourne. I'm PQMD's Executive Director, and I want to welcome you on behalf of our entire team. And thank you for taking the time to join us for this Pillar Talk, providing healthcare along the U.S. Mexico border. We are very excited to bring you perspectives from leading organizations and frontline healthcare providers who tremendously challenging job of providing acute healthcare and social services to the vulnerable populations that live through our border regions. They're here to help understand the complex layer of access to care on the U.S. Mexico border and avenues to support those on the ground. For those of you who are not familiar with PQMD, alliance of international NGOs and leading healthcare companies committed to promoting sustainable access to quality medicines, medical devices, and health and services in humanitarian disasters, populations in crisis, and for underserved communities around the world. Today, the work of our members is central to the global response to universal health care by promoting sustainable access to quality health care in underserved communities and displaced populations in crisis. So very quickly, I just want to review our housekeeping rules. Please type your name in the chat box and let us know your organization. And while we request all participants remain muted, we do invite you to use the chat box for questions and comments. And the session is being recorded and will be posted on the PQMD's community of practice this week. So please, you can go over it again after you've heard it today, and you can certainly share it with all of your colleagues and all of your partners. So now I have the pleasure of introducing Brian Scheel, who I think many of you know, who will be our moderator today. Brian is the Director of Strategic Partnerships for International Medical Corps, as an expert in international emergency response. Brian has worked around the world and has extensive experience building dynamic and partnerships with governments, the private sector donors, host governments, local leaders, partner NGOs to address the needs of crisis-affected communities. We are so lucky to have Brian guide us through this conversation today. So thank you very much all for joining us. And now, Brian, over to you.
Great. Thank you so much, EJ. And thanks to everyone for joining today's discussion. It is really such a pleasure to be facilitating the discussion. We have a lot to cover, and I know that everyone is looking forward to hearing from our panelists. So I will go ahead and start us off by providing us with a little bit of context. The number of migrants arriving at the border between the United States and Mexico hit a historic high of 3.2 million in 2023, with a record 2.4 million crossing into the US. These numbers are representative and connected to global displacement trends. 2023 saw an 8% increase in the number of people displaced from their homes across the world. And that number has only increased over the first half of 2024. Global migration flows are incredibly complex, with many factors such as violence, war, natural disasters and climate change, poverty, and more, pushing migrants to leave their homes and communities, and many factors pushing them to host communities such as the US. Notably, US-bound migrants hail from a greater diversity of countries than in the past and consist of more families and children. And many of these migrants are increasingly transiting through Mexico. In fact, roughly 1.39 million people from 177 countries have traveled through Mexico so far in 2024 to reach the US, according to a recent statement by the Mexican government. And for context, the United Nations is comprised of 193 members, so most of the world is represented among Mexico's US-bound migrant population. The largest number of migrants hail from Venezuela, which has been experiencing severe economic hardship for years, followed by Guatemala, Honduras, Ecuador, Haiti, and so on. Regardless of where migrants begin, the journey to the U.S. southern border is incredibly hazardous, with many migrants walking hundreds of miles and risking injuries, heat stroke, dehydration, drowning, exacerbated chronic medical conditions, and more. Migrants also face extortion, gender-based violence, and other threats to their personal safety from those who would take advantage of their vulnerability. And migrants that are caught crossing the border, excuse me, between established entry points by U.S. authorities face arrest, detainment, and other long-term legal consequences. Earlier this month, on June 4th, President Biden signed an executive order temporarily blocking migrants from seeking asylum when border encounters hit 2,500 a day. As daily encounters are trending around 5,900, this executive order has the potential to impact hundreds of thousands of people. It is important to note, however, this block does not apply to unaccompanied minors and victims of trafficking, who are among the most vulnerable. There is concern, however, that the executive order may drive families to separate themselves, with parents sending children across the border to claim asylum. The situation is no doubt complex, and the needs of people on the move are significant. Access to healthcare services, medicines, and other resources remains an urgent priority. There are many humanitarian organizations working to address these needs on both sides of the border. And we are incredibly fortunate to be joined by representatives from 3 organizations that are on the front lines of this crisis. And so it is my pleasure to introduce Pravash Budden, Deputy Senior Vice President of Emergency Programs for Americares, Dr. Brian Elmore, Chief Medical Officer at the Hope Border Institute, and Edith Tapia, Technical Advisor for Cross-Border and Asylum at the International Rescue Committee. We will be dropping more information on our speakers into the chat, and I would encourage everyone to take a look and get a sense of the depth of experience and knowledge behind today's discussion. And over the course of our discussion today, if you have any questions, please do not hesitate to drop it into the chat. We will do our best to leave time at the end to answer your questions. So before we get started, I also want to acknowledge that this is an incredibly sensitive political issue in the US. However, as PQMD is a non-political, non-sectarian alliance, the purpose of today's discussion is not to make judgments or discuss the value of policy related to migration. The purpose is to highlight the experiences of migrants, as well as the needs and solutions that we are bringing to the table as a humanitarian community. So with that, let's go ahead and jump in. Dr. Elmore, as an emergency doctor practicing in El Paso, Texas, I would like to direct our first question today to you. I wonder if you could talk about the health-related needs of migrants on both sides of the border. Who are you treating? What are you treating? And are you seeing any changes in health-related needs over time? If yes, what are some of the top trends that you're seeing?
Hey, y'all, it's a pleasure to be here. My name is Brian. I'm an emergency medicine doctor in El Paso, and I also work as the medical officer for Clinica Hope, a free clinic-based or shelter-based clinic for migrants in Juarez. So I get the privilege of treating migrants kind of along the full spectrum of injury and illness, from lower acuity viral syndromes in Juarez to kind of the severe traumatic injuries that can often lead to death that we see in El Paso. In Juarez, we treat migrants mainly in shelters, but we also do street clinics for unsheltered migrants, especially along the Concertina wire. We see kind of all the typical stuff you'd expect to see in a congregate setting, especially in refugee camps, viral syndromes, ear, nose, and throat infections, urine infections, a lot of the times we're treating mainly families and children. Probably 60 to 70% of our patients are women or children that we treat in Juarez. We do see a lot of patients with complex medical needs, and that's part of the kind of the puzzle, trying to figure out how to arrange their care within Juarez and how do we coordinate that care once they cross the border. I think a major push factor that's probably not talked about enough is this lack of medical care in their own country. So we do see patients that are presenting with really, really complex medical needs that requires a lot of effort to figure out how to coordinate that care. I think the biggest trend, the biggest change that I'm seeing on both sides of the border is an increase in traumatic injuries, specifically enforcement-related injuries. For the past couple months, we've seen a significant increase in injuries related to enforcement, particularly from Mexican immigration officials. There's this policy of externalizing the border, trying to push the border further south by Mexican officials to prevent migrants from ever reaching, the U.S. Mexico border. So we see lots of migrants with extremity fractures, with other traumatic injuries that do require further orthopedic care. And it's not just limited to Mexican immigration officials. We're also seeing these injuries from Texas National Guard and from cartel. Traditionally, the major traumatic injury was border wall falls, which is still very prevalent and probably the most prevalent traumatic injury. But we're seeing more injuries related to assaults, more injuries from pursuits by Texas state troopers. And then, of course, as we go into summer, we're seeing more heat-related injuries. And it's something I expect is going to increase, with the new executive order as it becomes harder to legally cross.
Yeah, thanks so much for that. And you touched on care coordination. And so as a follow-up question, I wonder if you could touch on the patchwork of health access points on both sides of the border, as well as coordination and communication, or maybe the lack thereof, between these various health access points.
Yeah, if there's one characteristic I think of border health, it's that it's fractured, and doesn't only apply to migrants. It applies to just normal El Pasoans and Warrensons. When I moved here a couple of years ago, I was surprised that our patients, and not just migrants, our patients are mobile. They move to both sides of the border. They seek care on both sides of the border, but there's no communication or coordination between physicians and healthcare providers on either side. Even within Juarez, there's no framework for treating migrants in which everybody can coordinate together. Under the Mexican Constitution, there's a nominal right to healthcare for everybody, even migrants. But in reality, there's numerous barriers to accessing healthcare in Mexico. So a migrant might be able to seek care at a clinic, but they're not able to afford for their prescriptions, or they're not able to afford their diagnostic imaging. That's kind of where we try to step in, and we try to accompany the migrant on every step of their journey to coordinate their care, both before and after. And I think another area that needs to be, that we need to work on better coordinating and collaborating. A migrant may seek care multiple times along their migratory journey, and, before they get to El Paso, and then after they leave El Paso. And there's, really no coordination between the healthcare work I'm doing here in El Paso and Juarez and the healthcare that may be provided, for example, in Tapachula or Colombia or Panama. And then distal to this point, when they go to their final destination, there's I don't think enough work being done to coordinate and collaborate with the upstream healthcare providers at their final destinations within the United States to ensure that they get the continuing care that they need.
Yeah. Thanks so much for all of that. It sounds like it's a really challenging situation. And I think it's great to hear how the Hope Border Institute is sort of working to try to navigate those challenges as much as you can. Edith, the International Rescue Committee has an incredibly extensive presence across Mexico and the U.S. and works both in the health sector as well as a number of complementary sectors. And so you're interacting with migrants in so many different capacities. I wonder if you could comment, one, on the mental health impact of migration, and two, what are some of the perhaps unexpected factors that are influencing migrant health and their ability to access health services?
Sure. Thank you, Brian, for that question. And it's a pleasure to be here with all of you. I would say that from what we have seen at the IRC, we, as you mentioned, we have a presence in Central America, South America, Central America, and Mexico. We have offices in Tapachula, which is the border from Guatemala, and a few along the southern part into the northern part of Mexico, Ciudad Juarez particularly. So we're able to sort of at times see the changes in even in hopes and aspirations as people are making their journey, at the same time able to sort of see some of the needs and the gaps in services. One component that we focus a lot in describing the journey, especially for service providers in the US, is understanding that journey and approaching it from like a triple trauma paradigm component, right? We know that it is, there is trauma that ultimately leads to people leaving their community. There are perhaps multiple traumas there. Then there's the trauma also of the journey, and in that comes, not having access to healthcare. As Brian mentioned, by law, asylum seekers and migrants, people on the move in Mexico are able to, or should be entitled to seek some sort of medical service. The reality is that it often doesn't happen. Barriers, not only because at times they're in transit and may not necessarily be in a place long enough to receive the treatment, to actually get an appointment to do so and afford the medication. We see that, again, as an additional component of trauma. We see a lot of chronic diseases that go untreated for prolonged periods of time that ultimately make their condition worse. The trauma of being stranded in the border, again, waiting a lot of anxiety that is not only it's palpable, right? Not only for adults, but for children, not knowing, when they're going to go in and when they're going to be processed, and then ultimately the trauma of the processing itself and being received into or incorporated into a new receiving community. There's a lot of health components and trauma components there that without a somewhat trauma-informed approach, a lot of this can sort of go unnoticed and ultimately have deeper impacts on their physical health. So that's something that we try to make people aware a lot, because we see it throughout the journey. I certainly have seen it, in a lot of the cases that we have helped sort of process, and not process, but connect, right, from some of our counterparts and our colleagues in Ciudad Juarez. We have been able to at times coordinate some additional care. Partners, are a big component of this. Ultimately, once they are in the United States, trying to connect them and give them perhaps a soft referral to a service provider. But even with that, there are a lot of challenges. And as Brian said very well, this lack of coordination and even just what they have access to in terms of records, there's a lot of disruption there that ultimately leads to more harm for the clients.
Yeah, and I really like that triple trauma idea. I think that I don't know that we really sort of think a lot about how difficult the decision to leave your home and your community actually is, and how traumatic that can be for migrants. But then, also, just how traumatic just the sort of regular uncertainty is of moving through locations that you are not familiar with and waiting along a border that you're not familiar with, in addition to any other trauma that might be experienced along the way. So I think that's a really, really, really powerfully said. As a follow-up question, we have touched on the health needs of migrants generally. Dr. Elmore, did an incredible job of, sort of detailing that. I'm wondering if you could touch on the experiences of women and girls specifically, including the risk of gender-based violence.
For sure. In Ciudad Juarez specifically, I mean, this is true across Mexico, unfortunately, but femicide rates are extremely high. Ciudad Juarez has a long history of this and, gender-based violence. Because of that, we have had the opportunity in Ciudad Juarez to have more support in that area than other border communities, but it's still not enough. I say that because we have that background and that history. There's been efforts to make this center stage in a lot of the responses at shelters or, you know, with the organizations that are present. Having said that, we still have the risk and the reality of women and girls being at times afraid to leave their shelter because of, you know, being assaulted. We know that they may not necessarily feel like they can go to school, they can have a job if they're being stranded because of this. And then a lot of it kind of comes from gender-based violence that leads them to have to move, and not having that recognized, you know, is a big impact. But I think I'll give an example actually of a case that we helped about a year ago. This was a Mexican indigenous woman from Guerrero that had been displaced because of a gender-based attack within her family, and her son ultimately ended up getting shot, lost his eye, and had an encrusted piece of bullet still in his head, in his skull. And the ability to get access in Mexico, even as Mexican nationals, was it was delayed, and they weren't getting enough of the attention. The indigenous language component also made it particularly challenging, and also the woman and the family were at risk, right? They knew that they were being, not only had that attack already happened, but there was fear of retribution for leaving, and they were afraid to be out. So there was a lot of security concerns within that case. We ultimately, they could not wait for the CBP-1 appointments, which, you know, are still in effect, but were starting to be introduced around that time last year. That is the appointment that you make with the U.S. government to essentially access the territory, right? It's just the beginning of any asylum claim. But right now, and even back then, the wait for that appointment can be anywhere between 3 months to 6 months. This family did not have that time to wait. So we were able to work with the CBP officials and also some immigration services to be able to present this as an exception, and we were able to get them across and ultimately, again, connect them to a community where they were going to be met by an additional family. So a lot of these cases are often like that is not an exception in terms of the type of cases. Unfortunately, there are too many of these, and there's a lack of recognition of that vulnerability and all the additional sort of components that sort of like lay on top of each other that make those cases more complicated. And even within the legal framework, it may not necessarily be enough for a relief on its own, right? So I think that also speaks to the need to explore more and see the impacts of gender-based violence in a lot of not only the medical care, but also the relief that is available to migrants.
Yeah, absolutely. I think it is really important that we do understand and that concept of double vulnerability. You know, migrants are vulnerable to begin with, but there are, you know, many groups, including women and girls, that have vulnerabilities on top of that. And it's so important that we understand and consider that double vulnerability as we are, you know, designing and implementing our programs. So yeah, thank you so much. Pravash, I'm curious if you have anything to add to the discussion regarding needs of migrants along the border, but I would also like to ask you about the health needs of migrants as they move away from the border and begin to settle into communities across the U.S. What is Americares seeing, and what is the impact on local free clinics and federally qualified health centers?
Thanks, Brian, and good to be with everyone today. Before I jump into that, I just wanted to paint a picture of the journey that so many do take. And as you pointed out, Brian, a vast majority come from Venezuela. I lived and worked in Colombia for many years, saw them coming in and exiting out and taking the most dangerous land journey in the world across the Darien Gap in Panama. And, you know, all of us can imagine going on a camping trip for several days, hiking in the forest, we're prepared, etc. And we're tired after that. now imagine people doing that with family members in tow, with real no known destination, and depending on goodwill of people, as well as all the risks and obstacles that come up traveling across multiple countries. And so when they do arrive at the US border, to Edith's point about the psychological wear and tear, the fear, the anxiety, and the stress of not knowing what the next day is going to bring adds up, and it is really breaks down the human body as well, apart from the accumulation of diseases and infections that Brian was alluding to earlier. And so what we see on the border are a vast degree of human health concerns, primarily driven by humanitarian relief that is needed across dehydration, trauma, exposure to the elements, and matched with chronic diseases such as hypertension, cardiovascular diseases, diabetes, and cancer, of which they may not have had medicines to those in the first place, or even if they did, they've been weeks and months without them. And so for several years, Americares has been providing support in California, Arizona, New Mexico, and Texas, mostly through our free clinics. And across the United States, we work with about 1,000 free clinics, and also have the great privilege of working alongside pharmaceutical companies that provide us with high quality medicines and medical supplies that we can move into the free clinics. What we do see, though, on the border is that as people come back and forth, as Brian said, it's not always for the long term. And as migrants are driven by economic opportunities, as well as family ties in other parts of the US, they will tend to move into more urban areas where they can access those services, those family ties, including healthcare. And so within Americares, we've expanded our work to include free clinics in the Washington, D.C. area, in Chicago, and in Los Angeles, because we are getting requests from longtime partners who are frankly overwhelmed by the number of migrants that have been coming into the clinics and requiring services. Now, to remind you, the free clinics throughout the United States are already serving a population of vulnerable communities that are usually undocumented, uninsured, low income, and have a whole set of chronic diseases. Because they are free clinics, they don't always have the right type of resources, maybe very understaffed, lower infrastructure, availability, equipment. And so the type of medicines and medical supplies they do get are very important to them, but they need even more now. And so what we're trying to do is expand our donations and services to those clinics to offset the pressure that they face. And we expect to see more and more of these cases come through the United States into urban areas. And I'd say one thing that Brian, our doctor on the border, alluded to was the fragmentation of services. Not only is it a fragmentation issue on the border itself, but it is amplified across the United States, where it's a patchwork of services, these little islands of support across the United States. And from a medical perspective, it's incredibly difficult to then coordinate and connect clinical services for individuals that don't have the written history that comes from support south of the border, as well as at the border, and then even through the United States. And that's really important to have, to be able to track things like infectious diseases, and to be able to focus on lab testing, vaccinations for the management of chronic disease, as well as diagnosing patients for ongoing treatment. And so this is something that is sometimes beyond the scope of what we can do as individual organizations, yet there has to be a collective effort from folks like us who do frontline healthcare with our partners, others on the call just now to coordinate with state healthcare systems and federal support as well. But as we know, across places like California, Arizona, New Mexico, Texas, every state has different policies, procedures, access availability or lack thereof. And so we all do our best to try and treat migrants and their human health needs as best as possible, but are also facing challenges with the policy and infrastructure limitations around us.
Yeah, absolutely. And Pravash, you mentioned that some of these clinics, some of these federally qualified health centers are overwhelmed, and so I want to maybe dive into that just a bit more. As Americares is a major distributor of donated medicines and medical supplies, both globally and in the U.S., are you seeing an increased demand for these resources among your partners? And are there any trends in sort of what they're communicating in terms of what their needs are? And you also talked about sort of moving into urban areas. Are there specific geographies that you are seeing are sort of more heavily affected than others?
Yeah, so in terms of some of the trends that we're seeing is that as patients continue to come in for services and establish themselves in urban settings, there's more documentation of chronic diseases. As I said before, diabetes, hypertension, and cardiovascular diseases are really the ones that surface quite a lot, and also tend to be dominant in quite a lot of the migrant groups that do come in the United States, not even just south of the border, but through other ports of entry. And so what we try and do is tailor our medicines and medical supplies to be able to treat the needs of some of the more of the chronic disease as opposed to some more of the general healthcare requirements. So that's one area that we're seeing trends in. Another is in mental health support. As Brian alluded to, there's an attempt to do some of that and triage at the border, and Edith, you tapped into this as well. But as people move on, they need longer term care, and making sure that they have access to the right type of referral pathways in urban areas, that they may qualify for any federal support or state support in mental health. However, we know that mental health support for migrants is an area that has significant gaps and not 100% fully understood with enough clinical services to support migrants. Things like translation, something very basic, but that's a huge gap that healthcare providers don't always have access to, or limited in how they can interact with patients. And then also just the number of mental health and psychosocial support clinics in any area may not be adequate enough for the demands that are out there. We do, like I mentioned before, the DC area, Chicago, LA are areas that we're expanding into, but also there's requests coming in from places like Atlanta, Denver, St. Louis, and Miami as well that we're keeping our eye on. And so it's an area where all those places do sound like sanctuary cities to some degree, but even if there is state and federal resources around it, they are not covering all the needs. And so organizations like ours do need to fill in the gap to make sure that people aren't slipping through the cracks when they need access to healthcare.
Yeah, absolutely. And so I think what we've done is we've done a really nice job, I think, of sort of sketching out there's a very clear there's a very clear need that stretches from when a migrant decides to to leave their community, all along the journey, and then when they arrive at the border and make their way into the U.S. But while there is this continuity of need, it's not matched by a continuity of services to sort of address those needs and how they're sort of changing, evolving, and growing over the course of their journey. So I have a couple more questions before we transition here to the audience portion. So this next question is for all three of you. Is funding keeping pace with the need, or are you starting to experience compassion fatigue among your donors? And outside of funding, what are some of the biggest barriers or challenges? I know that we've been talking about this, but what are some of the biggest barriers or challenges that you face as you are working to deliver these resources and services to migrants? Adith, let's maybe start with you.
Sure, thank you. Definitely funding is not keeping up with the need. It's insufficient. Many organizations, have seen or are trying to provide more with what they have, but definitely funding and sustainable funding is often very hard to have. A lot of this work does not have the option of having some of the federal grants, that some organizations work with, to make that sustainability. So it does come down to, more often than not, private funds, that kind of keep this work going. So there's definitely a need for that. I would also say for some programs, also like volunteers and people, but in a sustainable way. When I talk about, investing in communities, it's also investing in like the knowledge that's going to stay in a certain area, particularly El Paso and Ciudad Juarez are, as you had mentioned, communities that do not have a lot of resources as it is. So we want people to come or we want people to step in and do support with funding, with volunteers, but we also want, like, there's a lot of people locally, who are able to sort of do this work. And so investing in them, I think, is also a really big need that I would say. So that's one of them. And sorry, as with the second part of the question, I kind of just like went straight into.
I think you answered it. And I think that volunteer piece, I like what you said there. I think that, if you don't have that, sort of strong continuity around human resources, that can complicate what we've been talking about in terms of sort of the patchwork of services. Whereas if we are investing in local communities, there is, stronger continuity around those resources that we're trying to provide to migrants. So I think, that was, very well said.
And I can add quickly just an example that we have at the IRC. We have a program that it's called Evaluation Alliance for Human Rights. And they do a lot of mental health and physical evaluations that support a lot of the cases seeking asylum. And for instance, like some of the statistics that I always find quite astonishing is I think 1 in 10 people seeking asylum have legal representation. Of those, the 3 in 10 that have legal representation would be granted or win asylum. But with representation and an evaluation, 9 out of 10 will win asylum, right? And that network and that alliance consists of doctors and physicians and psychologists and psychiatrists in communities that are able to volunteer their time and sort of put that talent and their skill and to work in that sense. So there are various ways to sort of provide that sustainability for projects.
Yeah, I think that's a really striking statistic. Pravash, over to you.
Yeah, I would echo a lot what Edith said. I mean, financing and resources are always a challenge for nonprofit organizations. I would point to some specifics around the challenges about delivering services as we look at expansion to more free clinics throughout the United States. It's the capacity of the clinics to be able to take on more services, and all of those frontline doctors and nurses and pharmacists and psychologists are doing a heroic effort to be able to manage cases night and day and putting their own lives out there and sacrificing time and energy away from their families as well. And they don't have the right resources and the right infrastructure and support to take on more caseloads and have more complex services as well, really getting deeper into clinical and therapeutic care as well. And referral services don't always get followed up by migrants who may not understand the next step and the process of where to go, who to call, and are hesitant as well as taking on services. And so the more that they can turn to trusted doctors and nurses that repeatedly see them, that is really important in the experience for migrants in a new country, and that trust building to be able to navigate what is frankly a really complex system in the United States, even though, through our partners in the free clinics, they try and demystify the process and do their best to make it human. But that capacity support is really crucial to make healthcare services successful for migrants.
Yeah, absolutely. I think it's really clear that there really needs to be a concerted and coordinated effort around the needs of migrants. Dr. Elmore, last but not least, anything to add?
Yeah, sure. I mean, there's a huge funding need, at least in our part, for providing direct clinical care. We're like a small, scrappy organization. We don't have a grant writer or anything. Most of our funding comes from local donations. So, if we could, find a way to get more funding, we could provide care for more migrants that need it. And as regarding the compassion fatigue and the need for volunteers, there's a huge need for skilled medical volunteers, for skilled physicians. We have a huge base of local volunteers that dedicate an enormous amount of time to working with us. But we really need more skilled medical providers. In El Paso, if you're a U.S.-based physician and working in El Paso, you treat migrants every day as part of your normal job. So there seems to be a bit of a compassion fatigue for local U.S.-based physicians, that aren't super eager to come and spend their free time treating the same patients they would treat in El Paso and Juarez. So that's a need. We're always looking for more medical volunteers and new avenues for funding so that we can continue to support our Mexican physicians who we pay and provide medications and pay for follow-up care, labs, and diagnostic imaging and whatnot.
Yeah, absolutely. There are so many committed individuals that are on the front lines, but yeah, absolutely, more help is always needed. Well, I could keep going with questions, and I have more questions, but I want to leave time for audience questions. So Victoria, I've seen maybe some good questions come through on the chat. I may hand it over to you.
Yeah, sure. Thanks,
yeah.
Brian. Great discussion so far, everyone. Really interesting. And you've definitely inspired questions from the audience. So the first one that came in was, what sort of resources are needed to better coordinate health information at the patient level? Anybody want to tackle that one?
There's been an effort by some organizations to develop a mobile EMR, a mobile electronic medical record system that could travel with the migrant, and I think that's really needed. I know some of our partners are working on something similar, and I'd love to see something like that come into play so that providers can track the progress of their patients on every stage of the journey.
And I would add, as a non-physician, part of this, but working a lot with information provision to clients, I think that the more clear and the more awareness we provide to the people, the more that they are also like empowered to follow up and to use these, if there is something digital, right? So I think there's a lot of ongoing communication efforts that need to be sort of doubled down on the importance of why following up is important and all of that. Just adding.
Yeah, great points. Pravash, anything to add? Oh, you're on mute.
Information technology, access to medical records is one of the most important things. I know there were some initiatives from a few years ago trying to create a Pan-American system as well, starting out in Colombia and working its way up through key hospitals or networks of hospitals that could share a digital platform of record keeping. I haven't really kept track of that, but in terms of the user experience for it, it's still pretty complicated. I even have trouble navigating my own patient records on my app, and so I think it's a worthwhile effort to dig into more manageable and consistent patient record keeping, especially in the U.S. Once they enter into a system that has more technological infrastructure to manage it, but we're still a ways away from there. And the greatest concern of not having that is not being able to track not only individual needs, but infectious diseases that have been documented in one place and not followed up in another as people move fluidly through the United States.
Great, thanks. We have another question. If you could talk about any efforts that you are aware of to address the crisis or trauma of mental health or crisis stabilization issues of those that are coming across the border.
In Juarez, we have partners that offer mental health care. It's actually fairly easy to set up our patients in Juarez while they're waiting to cross with mental health care if they need it. It's a lot harder to do that in the United States, at least from my experience. And the reality is, once they cross into El Paso, the patient wants to be here for as little as time as possible. They want to move to their final destination. I think I've been brainstorming this with our humanitarian director. I think it's a model that would be really amenable to telehealth care, having providers offer telehealth care, phoning in that can continue to follow the patient. As regarding trauma-informed care and mental health services in Juarez, I think there's a robust system set up from my experience.
And I would just add that it has challenges depending on the location. As Brian said, in Juarez, there's a different system. We have seen and heard from my colleagues in Mexico the challenges with establishing even just a treatment or sort of protocols when, again, there's a lot of uncertainty and people don't know how long they will be there. So in a transient space, it can be more challenging. Even in Juarez or Matamoros, as we have heard, again, people may not be there long enough, right, for a process, or even some of the more traditional forms and techniques that have been approached always have to be adapted sort of to meet that more transient. So to Brian's point, I think something that allows the telehealth component would be interesting, but also recognizing that as people are, again, on the move, space, being in a safe space, there's a lot of things to consider. A shelter may not necessarily be the most adequate. We work in our office in Ciudad Juarez. We have caseworkers and we have a safe space where people are able to see and seek support, and a lot of that kind of works with them kind of more one-on-one. So I just kind of say that to sort of flag it. We can't assume people always are going to necessarily be in that spot where they are able and ready to receive it. I think there's some recognition in the trauma-informed approach. Is it has to be embedded into that.
Pravesh, do you have anything to add before we move to the next question?
No, I think Brian and Edith covered those well. Thank you.
Great. I've been getting a few direct questions, and one of them is actually about the mental health support that the providers are receiving, that you're aware of for those that are on the front lines and seeing what they're seeing every day.
One of the things that Americares has been focusing on over the past few years is support to frontline healthcare workers across the globe, obviously in places like Ukraine or Gaza as well, where there's large cases of stress and violence, and that shouldn't be ignored in the United States as well. And so we encourage our free healthcare clinic partners to bring up the support needs that they have for their caseworkers and for their clinical staff to be able to access resources that we can provide, as well as support networks for being able to take care of their own mental health.
Yeah, I can speak in terms of, I mean, the IRC, fortunately, we have a lot of resources at our disposal that are able to support, our staff, but we do see that with other organizations, partner organizations on the ground. And even when we do have those resources, sometimes it can be when you're constantly in the thick of it, right? To sort of make that time and prioritize and have boundaries and respect it. But there are some efforts, though always, again, need to be reinforced. In the El Paso Juarez community, I would say that a big breaking point for the recognition of a lot of this and taking time for this was around 2018, during family separation components. The communities alone have been so resilient and have had so much, but that, and also the massacre that we had in 2019, again sort of made us realize that we do need to take a step back, and we can't, resiliency can only take you so far. You also need to heal in order to continue to do the work. So I think there's been a lot more awareness and efforts, though when it's that fight, right, of you have a fire to put out, every day, and it's making that, and again, it goes back to the sustainability and funding and everything. We can only take care of ourselves so much and also respond to it. It's like finding that sweet spot.
I can talk a little bit about this too. It's as a healthcare provider providing care on both sides of the border, it's really difficult from like just the mental perspective. I think as far as I know, we're the only organization doing cross-border healthcare. And there's just always the idea that whenever you're not out there providing direct healthcare, somebody's suffering. And we get calls all the time to come see a patient that's critically ill in Juarez, and it's hard to separate yourself from that. And I recognize that, as hard as it could be, for somebody like me, it's much harder for our Mexican colleagues. They're there all the time, and that do also have to work, I guess, deal with the fragile security nature of the situation. But it's, as far as I know, there's no concerted effort to offer mental health care for providers here in Juarez. And I guess I would rather those be directed to the migrants we're serving. But I realized a couple of weeks ago how much it isn't affecting me personally. We had a security incident with a patient that we weren't able to treat due to criminal organization. And it like really profoundly affected me. And my wife finally forced me to go to therapy, and it's been good. And I recognize there's a need for that.
Yeah, thanks so much. And I know, I'm sure that there are many more questions. We are coming up to the top of the hour. And Dr. Elmore, I think I'd like to close out with one last question that I think is to maybe sort of building on, kind of the point that you just made. This is clearly such a complex and challenging topic. And I am just wondering sort of if each of you could talk about what gives you hope, like what keeps you going, like as you are working to navigate such a challenging situation and provide these incredibly needed services to migrants. And I guess are there any, what's the top lesson that you would like our audience to walk away with?
For me,
Go ahead, Brian.
Yeah, sorry, Pravash. For me, what gives me hope, it's the patients I treat. Hope is the primary driver of migration. You wouldn't, feel compelled to migrate without hope. And it's astounding to me, many of these patients, they're traumatized in their home country. They're traumatized along the migratory route. They're traumatized when they get to the border, and still, despite all of that, they maintain their sense of hope. And if they're able to do it, then I feel compelled to do it as well. And I feel compelled to work to live up to the hope and the faith that they have in, in us as a society. As regards to the final, I guess, take home point, you kind of alluded to this earlier. This has unfortunately become a political issue, and it shouldn't. It's a human issue. And, we're going into an election season. We're going into a holiday next week. A lot of us will be with family members, and this may be a topic. I think that any narrative that doesn't center the humanity of the migrant I think it's flawed. And I think whenever we talk about this issue, I think we need to make sure that the migrants and the people actually doing the, crossing the border, their narrative is the one that's centered. And so I'll just leave y'all with that.
Yeah, thanks so much. Pravash.
Yeah, Brian, what I'd say that brings me hope is that we're not alone in this. There is not only all the people on this call who are passionate about what is happening with migrants and immigrants and their lives as they cross the border and the emphasis on human health. But there is a huge and expanding network of people that are trying to do their best, from someone who shows up as a volunteer making sandwiches on a Saturday afternoon, to those, those who are trying to lobby for improved rights for migrants in the United States and elsewhere around the world. There's a huge array of concerned citizens and individuals that we should find power within, and it is powerful to know that this is not a hidden issue. It is right in front of us, and the more energy that we bring to it, we're going to find solutions. And a lot of us on this call and elsewhere know what the solutions are. It's not rocket science, and there are challenges and obstacles along the way, but we know what looks like sound and correct human health, and it's not a mystery, and collectively we'll get it done.
Absolutely. Edith.
Well, you guys have both said it. So no, I mean, have said a lot of, what also gives me hope. If anything, I would add is thinking that this is a marathon, right? Like this is, we think about, forced displacement, and last year, 1 in 73 people in the world are forcibly displaced. So that also just tells us, right, that this is going to continue to be a need. So that it doesn't give me hope in that sense, but it keeps me going. And I think the hope comes from, as Brian said, the people and the local partners or the national partners, the coalition that we have to do in order to have it be sustainable. Again, I keep using sustainability because I always think it's a marathon, right? We have to be, and so for me, that investing, co-share or sharing, best practices and learn lessons with people at every level, and making sure that we use our talent wherever, whatever our talent or our career path may be. If you have this concern, you can serve in multiple ways, whether it's as a volunteer with the clinic, or, in a local church, or whatever it is, in the advocacy that goes along with it on multiple levels, being able to proactively want to build that with others, keep me going.
Yeah, thank you so much, Edith, Pravash, Brian. I think really a very powerful discussion, and I think really inspiring final thoughts. So with that, EJ, I'll hand it over to you.
All right, thank you so much. We're at time. I'm completely inspired and grateful for everything that I've and I do have to say, Dr. Brian, your comment about keeping humanity at the center was actually the centerpiece of our recent Global Health Policy Forum in New York City, of which you're not a part, but you weren't a part. I hope you will be in the future, but I am so incredibly excited to hear you say that. And it just resonated so strongly. And I also just want to let you know that there are communities all over the United States that are standing with you, that are supporting you, and that are available to help in any way we can, as long as the information gets to those that are in a position to kind of rally the troops and support your needs. Because it just isn't really about money or resources, is it? It's about the passion and the willingness to contribute and be part of the solution. So I just want to say how wonderful it is to hear from all of you. So a real special thank you for coming out and being part of it. For those of you who are still online, if you could just please take the next 30 seconds. We have a 2-question survey that we'd like you to fill out that's in the chat. Please join us again as we continue these kinds of webinars and host these intriguing discussions. And also remember that the recording of the session will be on the PQMD of practice very shortly. So thank you so very much. Enjoy the rest of your day, and please go and click on the chat for the 2 questions. Thanks, guys, and thank you, Brian, for hosting. Really appreciate it.
Yes,
Bye.
thank you.
Thanks, everyone.
Amazing discussion, guys. Thanks so much. Really, really interesting.